Hello and welcome to our Making Digital Health Real series. This monthly series aims to provide a space to discuss emerging research, share career insights, showcase projects and networks for those interested in digital health. My name is Debbie Passy. I am a research fellow with the Center for Digital Transformation of Health's Validitron SimLab, and I'm honored to be the MC of this first installment of this 2025 series. I want to thank Christy Milley and the team at our center for their tremendous effort putting on this seminar series. And I also want to shout out the watch party in the Berkeley room on level 1 in Melbourne Connect. So before we begin, I'd like to acknowledge and pay respects to the traditional owners of the lands upon which we are situated today, the Wurundjeri people of the Kulin Nation, and I pay our respects to the elders past, present, and emerging. We acknowledge that sovereignty was never ceded, and so I also would like to extend this respect to all traditional owners of the lands from which our participants are joining us. So I want to start by introducing our brilliant guest speakers. We have Associate Professor Adrian Bickerstaffe. He is a computer scientist and health informatics specialist in the Melbourne School of Population and Global Health at the University of Melbourne. Adrian leads a specialized informatics team that collaborates closely with health researchers, general practitioners, policy advisors, industry reps, and builders of research computing infrastructure. His team leads the software development work for the colorectal cancer risk prediction tool, CRISP. And then we also have Associate Professor Jennifer McIntosh. She is an academic specialist in cancer screening and implementation science research in the School of Population and Global Health at the University of Melbourne. Her current research focuses on developing and evaluating interventions to improve colorectal cancer screening in Australia, including digital solutions for digital practice. Jennifer has expertise in cancer, sexual health, diabetes, implementation science, and using quantitative and qualitative methods. Today, they'll be sharing the tribulations and wins in a multidisciplinary project developing a novel risk prediction tool for colorectal cancer. So it's my pleasure to hand it over to Adrian and Jenny.
Terrific. Thank you so much. I'm going to start with me and then go on to Adrian. It's a great opportunity to talk about this. We had a lot of fun over the years, and both Adrian and I have worked really well together on this project. So it's nice to kind of present it and talk about our experience. But we are part of a much, much larger team. We'll talk a little bit about that at the end, but there's a lot of people who are involved in this, which also made it more challenging, but also a lot more interesting and a lot more fun. So the collaboration between Adrian and me is what we're going to focus on, but all of the other stuff was definitely a big part of it. So today I'm going to start by talking about the CRISP development, evaluation and ultimate trial. And this includes some slide studies we did on risk communication and implementation. And CRISP is the colorectal cancer risk prediction tool that we developed for use in general practice. Adrian's going to talk about the software development process, how his team supported the CRISP trial and lessons learned. The CRISP program of research, sorry, I'm just going to minimise that, started in 2013. So it was funded by a Centre of Research Excellence and led by Professor Mark Jenkins. So we're talking a long time ago now. And we said 10 years of research, but I have to say that's still going. Why would we look at developing a colorectal cancer risk prediction tool for use in general practice? So bowel cancer incidence in Australia is persistently high. And remember, we wrote this grant in 2012, and this is still the case. It's the highest in the world. We know that screening is not always risk-based. And what we are finding is that a lot of people who are at average risk of colorectal cancer are not doing the FIT test. And the FIT test is a free test sent by the National Bowel Cancer Screening Program to everybody every 2 years between the ages of 50 and 74. It's just changed. Younger people can now opt in. A lot of people are opting to have colonoscopies instead. And the other side of this is a lot of people who are at increased risk are not having colonoscopies when they should. So some people are over screening and some people are under screening, but not everybody is having the screening they should. So the aims of the CRE were to develop a tool that would increase risk appropriate screening. We followed something called the MRC framework, and this is the Medical Research Council of UK framework for the development and implementation of complex interventions. And this starts, it's a multi-step process. We started with the development, and this stage is really looking at what is the existing evidence. Is there already a risk tool that we can use? So we did a systematic review and we developed a model, and the model is the epidemiological model that sits behind the tool. The tool is the actual structure that you actually put the information into to get the risk. And then once we had information, we then took this to the expert panel for consensus as to what we thought was appropriate to develop into a prototype. The prototype was then evaluated for acceptability and feasibility in general practice. And we did a really small trial to test the methods for running a trial. We ran a larger trial and we looked at some implementation as well. I'm going to talk about each of these steps. So the first thing was building CRISP. How do we actually come up with the tool? The systematic review I mentioned, there was no risk prediction tool at that time that we could just use. So we had to look at all the other risk tools that were available for cancer in primary care to see what worked and what didn't work. What's the evidence for one that we're going to develop? Mark's team were also developing a risk model that we could use in the Australian context, and the expert consensus I mentioned as well. What did we find from the systematic review? There was limited evidence, there wasn't a lot there, but we did find that a risk tool would be more likely to be used if it was initiated by a patient, used by a dedicated clinician, so a person who really took ownership of using it, and also if it included health promotion and decision support. So it wasn't just giving people their risk, but actually sort of giving them information about how to improve their health and how to actually sort of act on the decision that the risk tool presented. Mark's team were trying to get a risk model published, and in the meantime, while we developed our prototype, we used the best available. The most appropriate one was the Friedman model, and that included all of these risk factors, some of which are protective and some of which are increased risk. So when we talk about risk factors, we're not just talking about things that are going to increase your risk, but things like eating fruit reduce your risk, taking non-steroidal anti-inflammatories, calcium and HRT also mitigate your risk of developing bowel cancer, and also some screening. Other things can increase your risk. So you have to put all of these together in a model and then interpret them so that they can be used in an effective tool. When I talk about the expert consensus, this is essentially the members of the CRE. We had a really complex, interesting group. We had a number of different work streams, which we would actually sort of take people with a problem and say, okay, this is the tool. What do you as clinicians think of it? Does it make sense to you? Do you think you can actually use this in a constructive clinical way? Then we would take it to the computer group people and say, how do you actually interpret this to actually work as a tool? We talked to cancer researchers. We had all of these different groups to see what else we could include and how we could actually interpret and build the tool. Then we realised we had to actually have a proper output. How do we actually communicate the risk to patients in a constructive way that was going to actually impact the screening that they would do based on the risk output? This was a fantastic study done by Grace Kim, and she was a medical student, and she actually sat in a waiting room with an iPad, again, that Adrian's team developed, and with lots of different risk outputs to see which one was going to be most likely associated with intention to do risk appropriate screening. I won't go into it in great detail. I'll give you all of the papers at the end. We found, really interestingly, if it had the government logo on it, people were much more likely to actually say that they would do the screening that was recommended. If it had a statement of absolute risk as well. So this was your risk of developing bowel cancer in the next 5 years is 0.32%. You're recommended to have a fecal occult blood test. And we also developed things called expected frequency trees. And the advantages of these were that they actually gave you the harms and benefits and comparative ones, depending on having no screening, FOBT or colonoscopy, depending on your level of risk. So that was really helpful to actually develop the output that we were going to produce. So we had a prototype at this stage, and this is CRISP version 1. So we took it to general practice and said, what do you think of it? And we did a feasibility trial. Now, this is really interesting, this part, the feasibility and acceptability we did was actually in general practices. And this is very much like the Validitron. So we had actors, this woman here is an actor, and they had absolute discrete case that they were. One of them was an average risk and one was an increased risk. And we had a GP who knew that they were an actor. But we went to their practice and said, as if this was a real patient, how would you introduce the tool? How would you use it? And we videoed it, and we then interviewed everybody within the actual practice as well as the actors as well to see what they thought of it and pain points, things we could improve. We did an analysis of the video, found some really interesting things, like as soon as the person sat down, they'd sort of go, oh, I need my glasses to see that. So, we knew the font was too small. So lots of really cool stuff came out of that. We found out from this particular study that it was acceptable and feasible in general practice, but there were a lot of things that were not usable, I guess. It was way too long. It was difficult for them to use. Different GPs were more comfortable using it than others. And when we asked where would it fit within the practice, definitely all different people within the practice in different practice roles all said that it would work best if it was delivered by the practice nurse for many reasons. Then everybody kept saying, why don't you just use it in the waiting room? So we had another really great student who did her honours CRISP-P study, and she sat in a waiting room with the new modified tool on an iPad and asked people to actually do it to see if they could use it without any assistance at all in the waiting room. 41% of people really couldn't do it without either asking her for help or obviously struggling with it and needing her to sort of step in and help. And this was particularly the case for people who were older or English was their second language. We also asked the practice what they thought about using it in the waiting room, and the administration staff said, do not do that in the waiting room. We don't want to have to deal with it. We don't want to ask people to do it. We don't want to have to deal with people's anxiety about it. So there was a lot of pushback. So then we did a big trial, and this was a randomised controlled trial. We also did an implementation study, and as you can see, this is due in 2023. We still haven't quite done that. So this is the CRISP tool itself, and it's really good to see how it works. So I'm going to show you. It's a concertina style. You can see that as the questions come up, you choose the information. If you have a family history, we developed this family history tool, which is really cool. You can claim, multiple different cancers within the family history. We were looking for particularly things like if there was a really strong family history or something that could actually even suggest that there might be a genetic disorder. We had what was called an active control in the randomized control trial. And in the control group, it was an active control because we gave them how to cut your cancer risk, which is generic information about how to cut your cancer risk. So we didn't just give the control group nothing. We also collected information from them in the form of a survey before they were randomized, so we knew what their risk was based on the government guidelines. So we had a risk assessment for everybody without actually having to use a tool in the control group. The CRISP tool was delivered by a trained researcher, so they were as if they were a practice nurse, and it was done before the GP consultation. They discussed the risk and they gave them printouts, a printout for them to have and then a printout for them to take to their GP, which gave them their risk with all the risk communication tool ideas that we had, as well as advice about what they were recommended to do based on their risk. Risk appropriate screening was what we assessed at 12 months. And we did that either with the risk or the NHMRC guidelines. We had 5 points of data to determine whether or not what type of screening that they had had. We asked them to self-report. We had GP records, hospital data, Medicare data, and national bowel cancer screening data. And where there were discrepancies between those 5 points, or they had a really complex polyp history, we actually took this to a clinical subcommittee and worked out each person's final outcome. It was really important to be reassured that we were doing no harm. And so we did ask about anxiety and particularly cancer-specific anxiety, and these are validated scales. No point in increasing everybody's risk-appropriate screening, but causing them a lot of undue harm through anxiety. We also asked about their risk perception, absolute and comparative risk. This is over the baseline, 1 month, 6 months, and 12 months to see if it changed over time, and also their intention to have bowel cancer screening. So the primary outcome we collected, we had 99% of the data, which was really great. And we found ultimately that we had a 6.5% absolute increase in risk appropriate screening, but you can see it didn't quite reach significance. But we found that there was a 20% absolute increase in people who were due for screening. So that was really a big impact. The downside was that over-screening, whether this was people having a colonoscopy when they shouldn't or having a fit kit when they shouldn't, was higher in the intervention group. So even though we were increasing screening, we were potentially increasing some over-screening. Now I can't see what I've got here. Increase in intention to screen in the intervention group at 1 month, and there was no other changes over time, particularly no increase in cancer or generalised anxiety, which is really important to us. So whizzing through this, and we're now up to about 7 years down the track. We did this neat little study where we went up to one particular practice that was outside of this particular and so this didn't include a group that had been involved in the trial. And we went to them and we said, we have this risk tool. How do you think we could actually implement it into and embed it into routine practice? And we did a lot of, explaining about what the tool was. This is just within one practice, as if it was like a laboratory for an implementation science study. We interviewed all of the staff. They gave us all their ideas about what they thought would work, about just getting it used in general practice on a day-to-day basis. We developed methods. We only sort of developed methods that we knew could be used in other practices. So, for example, setting up an alert system. So when people came in, they were, sort of the practice nurse would go, oh, that person needs to have their risks done because they're overdue for screening. We found education was really important for everybody to sort of get them up to speed. And then we would go back over every few weeks to sort of check that they were using the tool in the right way. And also if they had any ideas about how the implementation methods were working, if there were other things that might work better. And this happened over a period of time, over 12 months. And it worked really well until COVID came along. So they found it, the nurses really loved it. They loved being given this. They found it was really appropriate for them. They're much more proactive in doing preventive health stuff, which is really important. They loved the fact that they could talk about diet, smoking and screening because it brings up those as the questions in the tool. And they were very open to change. Time was always a problem and competing priorities. And the biggest issue was when COVID became a competing priority. Just one other thing there. Also, there are always a lot of changes in practice policy staffing that makes a difference over time with keeping something sustained within a practice. Now, this is a really neat project. I hope Maddie's here. Maddie Luke, an honours student last year, she decided to revisit whether or not we could actually sort of look at CRISP being a public-facing tool. And again, we enlisted Adrian's group for help, and we did essentially a usability and acceptability study to see if we could address some of the issues that we found in the previous study, because there is a bit of an interest in putting this onto some websites to make it available to people so they can assess their own risk and get their own risk advice. So she applied the changes to the tool based on the previous research. And that included addressing a lot of the questions that weren't well understood, and did a lot of interviews with 50 to 74-year-olds with the revised version of the tool. We also double-checked this against clinicians to make sure that what we were doing was valid. A lot of the guidelines had changed in the meantime. We want to sort of eventually bring this in so that 45 to 49-year-olds can do this as well, which has just been introduced in July last year. And then did quite a comprehensive analysis to see from the interviews what we might change and how we might change it. So we're going to make a few more changes, and it was really good because we had some really positive responses to it. People really, again, it was very acceptable. And we have a few more changes that we want to make. Maddie only managed to get 9 interviews, which was great for an honours project, but we'd like to do it with more and test it before we actually then maybe implement it into a website where people can actually sort of use it. And next interview set will include the 45 to 50-year-olds as well. We're still looking at long-term implementation. We're actually about to do an analysis of the 5-year follow-up of the primary outcome and an economic evaluation. So overall, we developed this tool over like 10, 12-year period, co-designed with a lot of people, all relevant stakeholders. And we found it was effective at increasing risk-appropriate screening in people due for screening, with a few limitations. And we need to look more at the implementation. Huge amount of people involved, some of whom are here, who I really appreciate their input. It was a really fun and very collaborative experience. I really have enjoyed it. This is a list which we will put somewhere else, and you can just have a look at all of the different papers that have come out of the study. I'm going to hand over to Adrian now. Whoops, no, that's something else. It's my cheat sheet for further questions. So Adrian, I'll hand over to you. I hope I've left enough time, and then we will have questions at the end. Thanks.
Thank you, Jenny. Can everyone hear me okay and see my presentation? Yep, all good. Okay. Well, thanks. There's the thumbs up. Thanks, Jenny. And thanks everyone for tuning in and for hearing about our work on CRISP. I'm just going to move this on my screen. I've got a little panel of icons. Okay, so this part of the talk is really about the software and informatics side of CRISP and the software development process and how this software came to be. So it's quite a different perspective to Jenny's part. I think to set the scene for this, I first need to outline the informatics team. So I head up a relatively small health informatics team that's based in the Melbourne School of Population and Global Health. We're a team of 5 working fairly close-knitly, and we're embedded in the school as a core capability of the school. So we collaborate across centres of the school using standard tech and standard tools, but we do collaborate more broadly than that. We're across faculty and open to external collaboration as well. So the objective of the team is to drive pop health research with best practice data management, using and developing robust software tools and systems that speed up the study process to facilitate and speed up research, but to also enable that translation. And the translational part, I think, is really central to CRISP here. But when it came to supporting the CRISP trial, research data management certainly came into play. So here we are. The software certainly was changing and quite rapidly. So this was developed in-house by our team using our research software engineer research software engineering capability from the ground up. So I think all of this has to be framed in the time. As Jenny said, it was around 2013 and 14. So looking back, a lot of this stuff almost seems trivial or obvious now, but at the time it wasn't. And there was a lot of learning to be done, and a lot of publications and research has happened since then. So it was really, I think we're in some ways at the front of the wave here. So the requirements of this software were really quite broad, and they were emergent. I think that's a key word, emergent. So we knew there would be a built-in risk model that was being developed as part of the CRE. That would be given to us in pseudocode. We would translate that into our own code, but we needed to test it. So we had a whole suite of test scenarios that were given to us with the anticipated risk output, and we had to automate that testing. So we couldn't do it manually every time. We would just run it and see what the outcomes were. We knew that there would be data entry, of course, into a tool like this. So you need to validate those fields to get good data, to get good risk estimates. So we wanted field validation, informative and helpful error messages. We knew that not all of the inputs would be relevant to all people or all users. So you would want to skip or hide some fields in some cases. Sometimes there would be a whole panel or a whole screen that you'd want to skip. This was all about screening recommendations. So it was crucially important that they were accurate, that the logic around the outputs was working correctly, but also that the outputs were clear and concise. Pretty early on, we knew that the outputs risk communication would be in terms of text and percentages, but also there were ideas to have pictograms, charts, infographics, so a variety of outputs. The PDF report came a bit later in the game, but did turn out to be quite popular with the users. And for the research side, it's not something that you can see, but there's a logging that's going on in the background where we're logging the inputs, the outputs, the timing across screens, and how people navigate between sections to see how they're using it, and do things like see where they're spending most time or the things that they're going back to. So the internal testing and qualitative research informed a lot of these changes, and that was really important, and it was iterative development at warp speed. So yeah, really one of the most dynamic, I would say, software development exercises I've been involved with. This is a bit of a history lesson and how we started off with CRISP. So this is version 2, and this was the home screen. So this is all about the journey that we went through to develop the software. So here's the home screen of version 2, and then you'd go through, and here's a data entry screen where you're entering some information about basic demographics and lifestyle. And there would be a series of these screens. I won't show them all, but it's what's called quite often a wizard flow, where you're moving forwards and backwards through a sequence of screens in that sort of one-dimensional way. You're going forwards or you're going backwards, but usually you're going forwards. And here would be a recommendation screen. So here's an example recommendation that's pretty straightforward. And in this case, it's just a textual representation. Okay, so a few examples of things that we learned along the way. And getting back to this idea of a pictogram, we thought, okay, well, we want a pictogram to communicate risk, and risk is between 0 and 100%. So it seems pretty obvious to have a 100-icon pictogram where one icon is 1%. That's what we tried. And then this was the 5-year risk in this case. And we realized that in a lot of cases, the risks are really quite low, but also they're usually fractional as well. They've got a fractional part. So that leads to this idea of partial shading of the icons. So you can see here we've got almost 0.25%. We've got a partial shading of one icon. But from the user's point of view, is that a quarter? Is that 2/3? Is it, half? It's not really clear. And this is really not an effective way to communicate those sorts of risks. So what we led to is this. This is a much denser pictogram. It's a 1,000-person or 1,000-icon array, where 1% is 10 icons in this. So we've got three icons shaded in the lower right there. We did revise, this was our first shot, we revised this and moved the shading up to the upper left. I think there's been work on the icons themselves and the colouring used, and perhaps there could be some more work on that. But generally, this was an improvement over our first shot. And here's another thing that we learned. Okay, so this was about lifetime risk, and this is lifetime to age 80 in this case. So, okay, let's do a line chart, we thought, and we thought, well, we'll crop the y-axis to be just the section that's used. And so in this case, the maximum is around 9%, so we'll go up to 10%, and that'll be our y-axis scale. What we found through the pilot testing is that people found this really alarming because they looked at it and saw these lines sort of rocketing upwards, which looks like it's really quite a dire situation. They weren't immediately looking at the y-axis and its labels. So that was another misstep and a lesson learned. So where we went with that was to keep the full 100% scale, which means that most of that chart is not used in a way, but it is a more accurate and communicative way of presenting that risk in a way that actually reflects the risk. That's our first shot at the revision. Again, this has been revised since then to be better than you see here. And then family history. So family history is always a tough one with these tools, and it can be quite laborious. So our first and early shots at family history use that one-dimensional wizard style approach where you're going screen by screen. Here we have the intro to the family history section. I think perhaps the fact that you need an intro is a suggestion that it's a problem in itself. And then you would go through to outline your family structure. How many of these relative types do you have? And then for the relative types, you'd have, which relatives on the father's side were affected by cancer, at what age. And there would be more of these screens depending on, how much incidence of cancer there were. So that was really a time sink and not very user-friendly. And that's where we led to replacing that whole thing with this interactive diagram. You can click around for the relative types where there can be more than one, like sisters and brothers, aunts and uncles. You can expand those sections down to add more relatives. And this is, again, not perfect. It could be made more readable, I think. But it was possible because we knew the extent of the family and the degrees to which we wanted to go. And I think most people can recognize a family tree at a glance. So this was a good improvement and a good speed up. So here we are. I've talked a little bit about the wizard approach. So that's where you're going screen by screen, next, 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 and maybe you go previous if you want to change something. And that was CRISP version 1 and 2. What the pilot testing showed there was that it really wasn't in line with how these consultations happen in primary care. So a patient talking to a clinician or even thinking about this stuff will talk in all different tangents. So they'll talk a bit about smoking and then a relative and then maybe their alcohol intake and their diet and maybe suddenly jump to demographics. When you're locked into a screen-by-screen approach, it doesn't lend itself to that sort of conversation. And I think one of the things that was found was that the GPs are actually writing things down on paper because they knew they hadn't got to that yet in the tool, but they knew they would have to input it somewhere. And that's not an efficient way to do things. So we revamped this whole user interface. And this is, as you can see, an accordion that's been flipped vertically. So it's a vertical accordion layout. And Jenny did show this before. In the vertical accordion layout, it's really a vertical stacking of patterns, of panels, sorry. And the panel that you've selected at the moment expands outwards and all of the other ones collapse. This gives you a nice compact way of looking at the panels, but it also lets you jump around. So you can pick any panel at any time and enter some data there. So you might enter some smoking information and go back to demographics, and then suddenly you're at medication. that's all good. You don't get to see the risks until you've entered enough information to get the risk, but that's fine. That was a much better way of doing things. And then we've got the standard recommendations screen. So you can still do all of the things that you would normally do with the recommendations. And here's an example of that. So I'll just talk a little bit about how we supported the CRISP trial. So this was, as I think Jenny outlined, recruiting patients in waiting rooms of GP clinics. I've got 732 there. I think Jenny had 722. I'm not sure if that's a typo or maybe 10 people dropped off. I'm not sure, but it was over 700. We were originally aiming for over 550. It's not often that you get more than you aim for. Quite often you have to compromise, but I think that's a testament to the recruiters and their charisma and charm. But hopefully a little bit of that was in the workflow as well. So the general steps went like this. So in the waiting room, the recruiter would have a tablet or a laptop. They would do an online consent with a participant. They would issue a baseline questionnaire as an online questionnaire. The participant would be randomized, and then they would be administered standard treatment or CRISP. And we wanted to log all of this information to analyze it later. The challenge was, how do we automate this and streamline it? Because everyone did the baseline questionnaire, but for the people who went off and did CRISP, a lot of that information would be asked again. It was still asked in CRISP. So we didn't want to have that duplicate data entry. It was not a good user experience. So here's how we solved that problem. So we had the online questionnaire tool for the baseline, and that saves responses in the way that any questionnaire tool does. It's usually to a database. And then in that questionnaire, there would be a clinic ID, and the questionnaire at the end would form a special link, like a customized link that you would click, and that would take you through to some randomization software that we wrote. And really what it was a randomization table given to us by the statisticians, and it set out the randomization schedule. So initially, all of the values in that used column were no, so all of the records were unused. And what would happen when you click through, it would say, what clinic is this? Okay, let's say it's clinic 1. Well, patient number 1 and 2 have been flagged as used for this clinic. So the next free row is row 3. Patient number 3, what treatment do they get? They get the standard treatment, and then we'll flag that as used so that the next person will go to the next row. So this was really an automated way of moving through that table and determining what treatment they received. And then there was an automatic redirection that happened. So that middle bit was all invisible and happened very quickly. It was all automatic, and an automatic redirection would happen to either send the session off to standard treatment, which was just a non-personalized PDF, or it would go through the CRISP. And if it went through the CRISP, the handy thing was that all of the relevant information from the baseline would be pre-populated in CRISP. What that meant was that not much had to be entered in CRISP to complete that CRISP session and then save all of that information to the database. So that was a nice speed up. And all of this had ID numbering and so on going on so that it could all be linked together ultimately to facilitate the analysis. Okay, just in the last few slides, I'll just cover some lessons learned here. And some of these are CRISP specific, but we have done quite a bit of work in decision support tools more broadly. And so it's coming from a lot of angles, I think. I will say there's agile development, which is that sort of iterative, flexible and not so locked in sort of approach to software development. But then there's researcher agile, which I think is another whole level of agile. Things are changing week to week and I would say day to day, because really what's happening is it's a research project. There's exploration and discovery, and it's happening in parallel to the research software. So that's really a big factor here. And so being embedded in the research environment was really important because it meant that the research team could really just walk up to the desk of the software engineer and say, what about this? Could we try this? Could we have a look at this? very quick turnaround. So that worked really great. I think it's important to define the target audience early and say who is this tool for, because that will determine the language that you use on screen, the wording, the sort of disclaimers, the risk presentation, the jargon. And it can also influence whether it will be considered a medical device. So that's important to consider, and things like disclaimers and whether it's an aid for discussion or it's actually a tool to execute screening in itself is quite pivotal to that consideration. Tools do need context, so you can't just put a tool out there on its own. You do need a supporting web page, a website with an evidence-based and some documentation and context around that. I think we've learned that having a multidisciplinary team with qualitative researchers is really essential, and really to get the stakeholders and consumer engagement happening really early on in the process, and to have them working in tandem with this development process. What that does mean, though, is that when you have people from different domains and different perspectives, it really makes the communication challenging. And particularly when you have a technical aspect, that adds another, I think, layer of challenge, and it's almost like a translational service needs to happen there to bridge that gap between the technical and the non-technical. I think during development, there are all of these tools for software development, agile development, testing, mock-ups, and so on. There's a lot of software out there for that, and that's all good. But don't be afraid of using what works for the research team. So if the research team can use PowerPoint to do a mock-up and they're okay with that, we can take that, we could turn that into a screen, and that was fine. You know, that worked well. If a Microsoft list was working for, or even a spreadsheet was working for testing, that can be okay too. You don't have to do something fancy. And just the last slide here on the lessons, I think the user interfaces really do need to reflect how these tools are used. And I touched upon that with the vertical accordion and how these healthcare conversations happen in real life. Healthcare professionals are time poor. I think we know that. This EMR integration comes up time and time again. It's not something I would wander into lightly. It was outside of the scope of CRISP. For this project, it can be done, but it does need to be considered carefully. I think we've learned, and it's well understood now, that the methods of risk communication really do matter. And a lot of publications have happened in that space in the last 10 years. Users, whether they're patients or clinicians, do like something to keep. The PDF reports were really popular. Clinicians could attach it to a patient management system, so that's handy for them. What works on screen may not suit a hard copy, particularly if you're using a black and white printout. And just lastly, this is a software-centric sort of lesson, I would say. When you're building these tools, there's frameworks and libraries that can help a software developer. They tend to go through crazes and fads, and just be careful, because something that might be super popular now might be forgotten in a year or two. So you have to choose for features, but I think you also have to select technologies for longevity. And that really leads into that last point there about the growing pains side of things. So a grant will typically support the research and development, but it's not so often that it considers also what happens after that and how you actually launch this and keep it going. So you need hosting, maintenance, support, and ownership to it, and all of that needs funding. I was thinking about this, and I think a hybrid approach could work, where having an embedded informatics team really worked well for this sort of project, to be prototyping and rapidly developing it. So maybe that could sit with a team like mine, and then the post-launch side of the maintenance and support, maybe that's something to be outsourced. So that's a wrap from my part of the talk, and this is somewhat of a duplicate of Jenny's acknowledgements, but I will say that it does speak, I think, to the multidisciplinary nature of this project, because the people there are coming from all different areas. And thank you to the funders, to the CRE itself, and the supporting agencies Yep, we do have some references here, which we'll share in the slides. We're happy to share the slides. But I think I'll park it there. And I think, Jenny, we're open to questions.
Nicely
Thank you.
done.
Yeah, thank you so much for such an insightful presentation.